Okay, legit. So we're gonna go over DKA, HHNS, emergency, and then Diego has some questions for you later on. Um, Diego, did you want to do questions at the end? I don't think I asked you about that.
At the end makes sense.
Okay, cool. So we're gonna start off with DKA or so what is the definition of our DKA? I was gonna start saying like the whole word of it, and I was like, no, because it kind of gives away the answer. Yeah, it's basically uncontrolled DM with ketones and metabolic acidosis. Pretty much at the end of the day, that's what you need to know. They need insulin. They don't have a way to move stuff into the cells because, yeah, it's most likely type 1 because when the body is not able to use the glucose for energy, it uses fat instead, like it says here. And if it can't use glucose for energy, it means that there wasn't insulin to move it into the cells. And then when the fats get broken down, a byproduct of that is ketones, which becomes which makes the body become acidic as more is released. So basic definitions. And um, Josh mentioned that it's typically for type 1. Why not as much for type 2 though? Because like it could still happen.
Type 2, they are still producing some insulin.
Correcto.
The problem with the cells are become insulin resistant because there's too much glucose.
Some possum, yeah. So type 2 is still making some kind of insulin. Is it really effective? Not if you're like my uncle. He don't control his at all. But if somebody has extreme insulin resistance, they're still producing insulin, they just have to produce a lot more, and it's probably not going to work as well, but not as likely to go into DKA because of that. What are some other risk factors for development of DKA?
Infection, illness, trauma, injury.
Dang, she went bam, bam, bam. I love it. I think the main ones that you would need to know drugs. Drugs. I forgot about that too. Yeah. I think the main ones you would need to know is missed insulin doses, um, or triggered by illness, like mentioned. Stress from MI technically could cause it too. There's a lot of things that could cause it. I love the fact it says drugs like cocaine. Very technically true as well. Let me put that one here too. Drugs. Pretty much anything that can cause you to have increased blood sugar and that there's not enough insulin going on. So that's like our big umbrella term, right? Like I like to think about a lot of stuff like that. If I just remember, like, well, it's most things that raise my blood sugar. Okay, what raises my blood sugar? You can answer a lot of the questions like that. Um, but yeah, so missed insulin doses, prolonged high blood sugar of 300 or more. Typically, your DKA is going to have a lower quote unquote high as opposed to your HHNS. It doesn't get as high as the numbers as HHNS does. Um, and I don't know. I don't know where I was going with that. Forgive me. And then the illness, adrenaline or cortisol count as your insulin effect. Sepsis is a big one for it. So any kind of illness or infection could lead you into DKA. Leading causes, I think we already talked about that. Well, kind of mentioned it. Here we go. I'm so bad at the typing and talking that I have an outline to the side and I'm just bringing stuff over. So forgive me. But yeah, so your main causes for development of DKAs, inadequate insulin or non-adherence. So if somebody's just like, I don't want to do my insulin injections, I'll do it later, or they forget. There you go. Followed by new onset. They didn't even know they had it. That actually happened to my cousin when he had type 1 diabetes and they found out when he was still, I think he was like maybe a little less than 10. I don't remember how old, but he didn't know and he went into DKA, ended up in the ICU. So that's a big one as well. Like if you don't know, then you're not going to know that you need to do something to fix it because you didn't even know that you had diabetes in the first place. But yeah, what are some manifestations you could see with this? Just physical for right now. And we'll go over diagnostics and labs in the next section. Yeah, that's the good start. This is the three P's. So you have your polyphagia, polydipsia, polyuria. Anytime you have increased blood sugar, you're gonna see it. Abdominal pain, yeah. Is it still bolded? It is still bolded. I just put abdomen. Abdominal pain, fruity breath. That's a big one for that, and that is due to acetone. I always thought they were referring to like the acetone in nail polish remover, and I'm like, that's disgusting. And then Diego, who actually went through some kind of science lab stuff, was like, no, acetone smells delicious. So the pure acetone smells like fruit and smells good. I too, that's why I was like, that's kind of nasty. But now I know better. Um, but yeah. You could also have some dehydration leading to orthostatic hypotension and tachycardia, like mentioned here. I think those are the main ones you would need to know. The only other one that I would say, um, like, is there anything else that I'll give you guys the opportunity? Is there anything else that you guys think would be like a key finding for DKA?
Kussmaul's respirations.
Kussmaul's respirations, yeah. So it's defined as a tachypnic, fast breathing, deep and fast. And the reason that's happening is because they want to try to correct acidosis by using the respiratory system to compensate for that. So they're trying to blow off extra CO2 to kind of rebalance our scale and lead us back to normal pH level out of acidosis. Yeah, those were the main ones, and then this one can kind of go for both. Altered level of consciousness can even lead up to coma if you have cerebral edema. That yeah, that could totally kill you. I could see how that would kill you. So, shit. Is everyone done with sim? Or is there like one more
There's one
sim?
more. I think there's one more group.
Yeah, this is the last
Okay.
week. Every
Okay,
other
I was
class I
gonna
think is done with sim.
dang it. I was gonna say because one of your patients is DKA. So I was gonna mention that, but I'm sorry, Ryan. I'm not gonna ruin it for you. Forgive me. Forgive me. But yeah, so three Ps, which will happen with anything with your high blood sugar. Kussmaul's is pretty key finding, pretty breath, and yeah. The other is like altered level of consciousness you could see in the HHNS and abdominal pain. Going into diagnostics and labs, obviously you're going to need a glucose. I would hope that that's an answer choice that you choose. If not, live your best life, queen. So what kind of numbers are we looking for at this? Like, what do you expect to see? Yeah, so it's still elevated, but again, not as much as your HHNS. So you're gonna see like greater than 250 to 300. It's still like a lower range than what we would be like, wow, that's really sky high. I had this lady that was in one of the care homes, and she would constantly be at like three something or 400. But she said, oh, I'm doing just fine. The second it went to 200, she got confused. Weirdest thing I've ever seen. I don't understand that one. But in any case, she had type 2 diabetes. So, running into those higher ranges ironically did not cause her too many problems. I mean, I'm sure it wreaked havoc, but not to the point of DKA or HHNS. So that was nice. Next up, you have your BHB beta hydroxybutyrate. Diego, science guy, did that sound right? I
No.
feel like it did. Did it not? I felt like it was right.
Say it
Okay,
again?
you say it then. Oh God, no, don't make me say. Okay, wait, hold on. Hydroxybutyrate.
That's right. Yeah.
Then why'd you say no?
I think you said it differently the first time.
Oh, come caca. Okay, yeah. So know your values for this. This one is the main ketone body produced, so it's a good measurement for ketosis. I have a dumb way of remembering this. I see Ryan put this one is greater than 3.8, should normally be less than 0.28? 0.28, yeah. I had to like figure out where the dot was here. So here we go, right here. This is my little saying, 3.8 she DK8. If that helps you, cool. If it doesn't, ignore it. But that's how I remember it, unfortunately.
I don't remember which one of us came up with that, but
That
it's
was
fine.
me. That was
Was it
me,
you?
Queen.
Okay.
Me. I always come up with the stupid ones. But it's functional. I'm here for functionality. So it helped me remember because my rote memory is horrible. So it is what it is, right? All right, what do you expect to see on your ABGs?
Low pH.
Low pH. What about your bicarb?
Low.
Low, shawty got low, low. Yes, yes. Yeah, so DKA is described as anything under 18, under 5 is severe, and if you remember 22 to 26 or 28, depending on where you're looking, is your normal range. So getting down to 5 is a little scary. I think it's a little scary. And then here I was talking about anion gaps. So what is an anion gap? Exactly.
The difference between the cations and the anions.
Yeah, so it's difference between your cat ions and anions. Sorry, wait, I'm trying to read Jude's thing. IDK is under 18 for bicarb. Yeah, so HCO3 bicarb is decreased, and these are the levels that I was referring to. I'm so sorry. So yeah, under 18 is defined as DKA for bicarb, and then under 5 is extremely severe for bicarb. But yeah, so your anion gap is used by what's the word? You have like your little formula, right? And this one is a good thing to use for DKA specifically, and it's going to be like your good measurement of metabolic acidosis and correction of it. And if it is greater than 12, it is high. There are technically two different formulas. For the sake of your testing and for the sake of what's going on in this class, I will only mention one. Do know that there is another formula and your ranges are affected by that though. But yeah, so I have all that here. So it's useful because it identifies the presence of unmeasured anions like your lactate and ketones, which, you know, would show up more, so to say. Diego has a better way of explaining it than I did. It shows the difference between when your body is having acidosis, it will lead to bicarb to become decreased because it is a buffer. Love that for you. But yeah, so that kind of feeds into this. Your main influencer for an increasing anion gap is the lowering of HCO3. And I know someone mentioned the formula somewhere up above. Oh, it was Josh. I see you. Here I am. Here we go. Paste that. Yeah, so it's your sodium minus your chloride plus bicarb. I think the ones you were taught in class were not including potassium. I'm not doing the formula that includes potassium because I don't want to confuse nobody. Just know that your range for this formula is 8 to 12. DK is anything above 12. It's high. Now, it's really important for your anion gap in this situation. You want to be able to quote unquote close the anion gap. So that means just basically lowering that number back down below 12, getting into our normal range of 8 to 12. And you know, so excuse me, sorry. My brain is backfiring. It's been a long day. Brain. I think I need a nap. Okay, let's reset that. But yeah, so how would you go about closing the anion gap? That is the ultimate question I was attempting to ask. Dear God. Help. Help. How do you close the gap? Pray for me. Yes. So in this context, it's going to be insulin as your main contributor because you're closing the gap refers to your bicarb returning back to normal. as seen in this formula. If we increase or if we decrease the bicarb, number goes back below 12, goes to 8 to 12. So the biggest thing is you have to fix the underlying issues that's causing the increased anion gap. So in this context for DKA, administering insulin is the way to close the gap for your anion gap. Because your fluids, they're gonna help. And you're right that we do have to give fluids, but your insulin is gonna be the thing that actually lowers your anion gap. So just keep that in mind. Keep that in mind. Keep that in mind. Just a thought. Oh, he's got the whole paragraph. Normally, when your bicarb is decreased, this leads to chloride increasing to compensate. When you have hidden acids, then those are adding to the amount of anions, which means your chloride doesn't compensate. Dear God. Cough, cough. Yeah, it also lowers the potassium. Yeah, we'll go over that in treatment too. And I actually have that lab for potassium here, so we'll talk a bit about it in a second. Why would you want to be monitoring creatinine and BUN? Dehydration, fun stuff, shows how our kidneys are performing, right? So if I end up having severe dehydration, I can have maybe even an AKA. Why not? Throw some fun into the mix, shall we? So you might expect to see an increased BUN and creatinine. Okay, Diego says anion gap separates between acidosis due to hidden acids versus other cause like hyperchloremic metabolic acidosis. We watched this guy on Instagram. I think, what was he, like a renal doctor? And he was upsetty spaghetti because he was like, no, you're gonna give him hyperchloremic metabolic acidosis. Does no one care? And it's like, right? It was like a renal doctor, right?
I think the doctor himself is actually I don't think he does renal, but he makes, like skits like that. And he was playing the nephrologist in that one. And kind of like the whole video was he was making fun of everybody always makes fun of the ortho doctors. It's like a common thing.
Times. But yeah, that was a funny video. I wish I remembered his name. I'll find it later. But yeah, so now moving into that potassium, which I know Josh mentioned earlier, that administering your insulin lowers your potassium. So that's one under 3.3, don't give insulin, give fluids first and attempt to correct as well. Let's see where I'm at. Okay, potassium. There I am. Where am I at here? Why did I scroll down? My computer's glitching out. I'm scared. The hackers got me. So yeah, so like Josh was mentioning, he's saying there's some low values. And that was what I was going to get into next, Ryan, is that it could rise initially due to the metabolic acidosis, ending up pushing potassium out of the cell into the blood and causing increased serum levels. When we diurese or when they start to pee a lot, osmotic diuresis, it returns back to normal or lower. And then as soon as we start that insulin therapy, we also risk pushing more potassium back into the cell. So be aware that at different stages, depending on what is going on, your potassium could be high, low, or normal. It could be all over the place. So just be aware what stage of treatment you're in.
Thank you.
And what happened? Scared me. I'm so sorry. For your sodium, do you expect that to be high or low?
Be high.
Ironically, and this one always tripped me out, delusional hyponatremia. I always thought that one was weird. Let's see, high osmolarity, one of the two, of blood due to high glucose removes water to the intravascular space, and that causes your delusional hyponatremia.
Good.
Enjoy.
Say thank you.
Thank you.
Thank you.
Oh, I heard the little kid. How cute. A child.
Hey. Oh.
This is Ashley, a child. But yeah, so that one was always strange to me because I was thinking, okay, they're peeing a lot, so I expect things to be really concentrated, and I would have thought hypernatremia, but due to your high amount of glucose being able to pull more water into the intravascular space, you end up with delusional hyponatremia. Weird stuff.
Hmm.
And also, as you pee a lot, you lose more. Good times. Okay, so now your serum ketones, what are your values here?
Positive. Ketone positive.
Yeah, you're gonna see serum ketones as positive. What are your lab values for it?
Honestly, don't focus too much on the lab values for that.
Do we need to know those?
Hey,
No.
toma caca. You know what? Just because Diego ruined what I was trying to do, I'm gonna be salty. I'm gonna be salty, unlike our delusional hyponatremia DKA patient. Yeah, so 0.6 to 1.5, you want to be rechecking that blood sugar in the next few hours. I have a little saying for it. Between 0.6 and 1.5, check that sugar one more time. It kind of rhymes, kind of pushed it, but it works. It's kind of like the SAVE acronym that Robbins went through. And then greater than 3.0 is immediate treatment, more than 3 immediately treat. Again, I kind of pushed it, but we're running with it, right?
No, I came up with that one.
I think you did. I came up with the other one.
Yeah.
Yeah, so urine ketones are also going to be positive. 1.5 to 3 is risk for DKA. Yeah. So they're gonna be DKA, and if it's greater than 3.0, then you have to immediately treat them. So yeah, those are just normal values. Apparently Diego doesn't want you to focus on them. You kind of don't have to. But in any case, your urine ketones, know when to test them for your type 1 diabetic. So when do you test for urine ketones? I mean, obviously if they're in the hospital, but beyond that. High blood sugars. Yeah, I would hope that you would choose something like that. Yeah, so if the blood sugar is over 250 for 2 consecutive tests, you will be looking for your urine ketones. Before exercise, if I'm assuming that's blood glucose, is high and infection, anytime there is sickness or infection, you increase blood sugar. Again, it's kind of the same thing. Anything where blood sugar is going up and maybe not being controlled. And yes, Bella, blood glucose greater than 250 for 2 tests. However, it's greater than 600, you can assume HHNS. Depending on greater than 600, what, the blood sugar? I think that's really dependent on what's going on as well. I mean, is it possible for DK to get up there? I suppose. It's not as likely to happen, but never say never. I think the main differentiating factors is going to be underlining pathology and past medical history is going to be a big play in it, and then also looking for your ketones. Of course, I'm sorry, not the curse.
I mean, at the end of the day, a lot of both of those conditions lead to a lot of the same symptoms and complications.
Very
So,
similar, but one has acidosis and one doesn't. That's like your
yeah.
big differentiating factor. So your DK, it's right in the name, acidosis, while as your HHNS does not have acidosis.
Yeah.
But
But
yeah,
typically, if you know they're type 1, you're gonna check the ketones. If they're type 2, they can still get DKA, less likely. But just use your judgment, their presentation. If they're type 2, they could be, like above 300, have a lot of symptoms. They might not be making ketones. I mean, they're less likely to make ketones because they still have insulin production and they still have, the insulin production, but it's just kind of worth kind of keeping in mind.
cool beans. Oh yeah, so when to test, blood sugar for greater than 250 for 2 tests, illness, infection, injury, exercising if it's already high, and for pregnancy before breakfast and checking every day if it's again over 250. There's that number again. Moving on to osmolarity. Do you expect this person to be hemoconcentrated, hemodiluted, or kind of right in the middle? feel like this one messed with my perception. It's a little bit variable, right? So it could actually be like normal to a little bit low, because remember that the high amount of sugar that's in the blood is able to pull more fluid into the intravascular space. So it could kind of dilute things down, but it's usually normal-ish. Whereas you'll see with our HHNS, normal ain't the truth. Yeah. Yeah, it's gonna be high. They're super concentrated. Why would I want, yeah, hence the name hyperosmolar. The names really help you out. Why would I want an EKG on this person? Why would I want them on telly? Sunum.
So because
Potas.
the electrolytes are gonna
Yes.
hold in place.
Yeah, so we're looking for any T-wave abnormalities related to potassium imbalances, mainly potassium. I mean, there's other things that could affect EKG and heart stability and etc. But for this one, mainly potassium is going to be your main player because it's so variable. You could be high and then we push a whole bunch of insulin in there and we drop it out. So yeah, flattened T waves is hypokalemia and the peak T waves is hyper. So if it's high, it's hyper. If it's flat and low, it's hypo. Makes sense to me. That one actually correlates, thank God. And then your chest x-ray is literally just to rule out any cardiopulmonary cause or anything going on in that aspect. They just throw that in for funsies, just for funs. Okay, so in your management, I know we've mentioned a few things. What is your like number one priority for this patient? What is the first thing you're gonna do? Fluids. I love the way Robin says it. It's so funny to me. So yeah, it's gonna be fluids first. I even wrote it like that. Obviously kind of before you dilute everything down by pushing a whole bunch of fluids in, you're gonna make sure that you get your blood draws prior, and then you're going to give 1 liter over 1 hour. I think it's mainly
Really?
NS. Diego, correct me if I'm wrong on that.
I believe that's right.
I'm not sure about LR just because it does have a lot of electrolyte and other stuff already inside. LR is more for burns, yeah. But yeah, I know we mentioned electrolyte replacement. Now your potassium, that one is going to be IV piggyback solely. Cool beans. If you have a central line, your max rate will be higher. This is also dependent on hospital policy, so mind you on that. If you have a peripheral line, it's greater, or 10 is your max, and then your central line is 20 is your max per
Yeah.
hour.
Also, sorry, I just wanted to bring up because
No, yeah.
we were talking about this, and like technically in the notes it does say NS, and that's pretty typical. But kind of like when we were talking about burns, LR was preferred there due to the fact that it has some bicarb, which helps with acidosis. So in theory, LR can be useful. Also, kind of like we talked about, if you're giving them a lot of fluids, a lot of NS that could lead to hyperkalemic metabolic acidosis. Like it could make the acidosis worse technically, although obviously your priority is ABCs in this situation, but this is something to keep in mind. Probably just follow your protocol, but in theory, LR is technically technically better.
I'm gonna fight you a bit on that one because I know that LR has other stuff in it besides your bicarb. So you can end up messing with your electrolytes even more.
Usually LR is more balanced. It's actually usually better for electrolyte management than NS.
I feel like good luck finding out on the floor.
That's the issue. The issue is that LR is not very compatible with things, so that's why they don't use
No.
it. But if like they don't need anything else other than just fluids and insulin, um, and insulin's running its own line, then LR is technically better because LR in general is a better fluid than NS, but it's just not compatible with a lot of stuff.
Also
Hence
want to
why,
note,
oh sorry,
oh,
I
go
was just
on.
gonna say hence why LR is used in OB because a lot of those people are just there to give birth and there's not usually things wrong with them, so they get LR because they're not expecting to need something else through IV. So it's just like, okay, we give you the best fluid.
Yeah, forgot what I was gonna say about this. I'm sure it wasn't anything important if I forgot about it. But yeah, fluids. like Mr. Robbins says, fluids, because obviously if they are bottoming out, that would be fun, right? We love that. No, we don't. First things first as well, potassium, making sure that you do that IV piggyback and making sure, like Josh mentioned earlier, that your potassium is greater than 3.3 before insulin, because insulin pushes potassium back into the cell and we're going to drop it out more. So don't do that, preferably. I mean, unless you want to, do you, boo, and lose your license, but, I'm good personally. And obviously our last thing is insulin. So we would think, like our main problem is blood sugar. So some people think like this is the first thing that should be done. Wrong, sorry. It's actually going to be after everything else has already been done. Your potassium is in range, you're giving fluids. You're going to be giving a bolus followed up by a drip. The 0.1 unit per kilo per hour. I don't think you need to know that deep down. Just know it's IV regular insulin. That's the only one that you could give. That's the only one that you could give. That's the only one you could give. I'm pointing at the camera right now and I know nobody can see me, but IV regular insulin only. Please, porfa, please. Once you get blood sugar less than 200, you're going to decrease the insulin rate by half or whatever your facility wants. And make sure that you're not dropping your rate out too fast. So preferably they don't want it over 100 per hour to go down, because you can end up with some weird fluid shifts and ending up with cerebral edema from those fluid shifts. Diego, if you know the patho on it, you can go roam free right now, but I do not know the patho on that. You don't know it. Okay, thank God. I was like, I thought I was the only one. Because I really don't. But yeah, so
Oh,
yeah,
no, sorry, I was muted. What did you want the path on?
I was saying, do you know how the fluid shifts like happen when you drop the blood sugar too fast, how it like messes with fluid balance and why it causes cerebral edema?
Yeah, so if you are leading to a large decrease in the sugar, then it causes kind of the osmolarity to decrease too fast in the intravascular. So then your intracellular becomes more os like the osmolarity is bigger. So then you start having fluid shift into the cells, and then that's where that happens. And then you have those cells puffed up, and it happens to, cause the cerebral edema for that reason. Fluid shifts into cells. Your brain has cells. Boom.
Not sure if mine does because y'all have heard me struggle throughout most of tonight, but pop off. But yeah, so that does it for DKA. Is there any questions, anything that needs to be clarified? I know I went through it quick, and I know I kind of just hit on really big bullet points. But if not, we'll go into HHNS. I know you guys have your test tomorrow. I know you guys probably want to get out or ask more questions and whatnot. So we'll try to get through this, pretty moderately quickly. I'll try not to talk as much. Cool beans. Okay. So moving into your HHNS, characterized by hyperglycemia, hyperosmolarity, dehydration without significant ketoacidosis, because we're not transforming fat into energy at this point. What is your leading cause here? Dehydration, glucose greater than 600, bicarb greater than 15. That is perfect. I'll put that down here when I get to it. Infection is your leading cause. Where's the dang it? Especially sepsis. Sepsis does everything wrong. I don't like sepsis very much. But yeah. Small to absent ketonemia, that is also true. Risk factor as well, older than 65. Obviously more common in diabetics type 2. Stress, another health condition, taking meds, or they stop taking their meds that they are supposed to be taking to manage their blood sugar in the first place. So we love that for her. Okay, manifestations, I know is already mentioned. So plasma glucose level is greater than 600. It will be to the skies. She will be flying. We love that for her. Maybe not so much. And this person, like mentioned earlier, is very concentrated. They're peeing out a lot. Noted here for hyperosmolarity and dehydration. So osmolarity, whatever the difference is, I never figured that one out. It's 320 or greater. So just know they're gonna look pretty concentrated. And yes, you can lose up to 9 liters, and that's a lot. I don't even drink 1 liter of water in a day, so I can't imagine losing 9. Like,
That's bad, bro.
what that's bad, bro. This is the guy that drinks like 3 to 4. He's got a problem. Yeah, he is living in the bathroom. Thank you, Ryan. I appreciate that. Exactly. Somebody gets it. But yeah, so higher osmolarity. ABG mentioned earlier by Josh, it was greater than 15. Oh God, what's the unit? Milliequivalents per liter. I forgot that that middle letter needed to be capitalized because we don't have any ketosis or acidosis going on. So going along with that, your pH is going to be relatively normal. It will be greater than 7.3, little to no acidosis. Probably not acidosis though. So I kind of gave away this answer. Ketones, no. Little ketonuria, if any, and then low to no ketonemia. So that's ketones is mainly for your DKA. Can you still see it in HH&S? Yes, but not to the point of like it causing much to go on. Ryan mentioned losing up to 9 liters a day of water, super dehydration. And of course, with our fluid shifts and whatnot, you can have cerebral edema leading to altered level of consciousness. Love that for her. Now, again, the diagnostics, they're all the exact same things as what we went over above. So I'm literally just going to do this. Oh, I didn't write similar to above. I wrote it on the next part. So similar to DKA above. So you guys can just refer back to that section up at the top. Your BHB, that one was to, help and look if there is like ketones going on. That's to rule out your DKA in this case. CBC, BMP, making sure your electrolytes are chilling, serum ketones and urine ketones, seeing if there's anything going on there. Also rule out DKA. Osmolality, this person's probably going to be really concentrated. ABG, it's going to look relatively normal-ish. EKG, again, looking for electrolyte imbalances, if there is any, making sure that there is no cardiac instability, and your chest x-ray, because they just like to throw it in for funsies. We love that for her. I like DKA and HH&S because they are so similar that it almost helps me think about it. So again, it's similar as above. You're going to be giving IV fluids. You know what? I just realized I didn't write it out like that here. There we go. IV fluids, insulin drip, and yes, that was the other thing I was going to mention. And your electrolyte replacement, especially potassium. The one difference in your management here is heparin, because if you are severely hemoconcentrated, you run risk of throwing some clots. It's chunky. It's like, I don't know why this came to my mind right now. It's like if you make soup, like a really thick soup or syrup, yeah. I don't know why soup came to my mind. I think it's because I made a chicken gnocchi soup last night. Soup.
Yeah. I think syrup
Yeah.
makes more sense because it's already sugary. It's like a sugary thing.
Makes more sense. I think soup's just in my head because that's what I want right now. Oh yeah, so your hemo concentration increases the risk for clots, so your heparin is there to attempt to combat that. Okay. Now, in general, what are some complications you could think of? Obviously, I know we have hyperglycemia going on in this. We mentioned clotting with the heparin. Hypovolemic shock in specific, yes. Volemic shock. We have AKIs. Hypoglycemia, always with your treatments. Remember, we can go too far the other way, swing them too far. Yep. Oh, I didn't write that. I thought I already did. My bad. Blood clots is another one. Same thing, we have our management as IV fluids, so we can end up going too far the other way and send them into FBO. Be especially cautious with your patients with pre-existing chronic health conditions such as chronic kidney disease or CHF, anything that reduces their ability to clear or manage their fluid balance, because we can very easily send this person into FVO. So just something to be aware of. We've talked a bit. Oh, that's why it is very important to check your urinary output for most of your patients. I don't know. I was always on a telemetry floor, so for me it was just like, yeah, everybody has a strict INO. It just kind of like got ingrained in my head. I don't know why. We have risk of how do you spell this? Hypokalemia, technically they're also going to have possibly hyperkalemia, who knows, but most likely hypokalemia with HHNS, because we're giving insulin, pushing that back into the cells. Let's see, is there anything I missed? Ooh, I did miss one. We talked about it though. Cerebral edema. That's not how you spell cerebral. That's exactly why I had it written to the side. So this is if insulin is given too fast. So please remember this. If you give insulin too fast, you're gonna cause them to have a swollen brain. That is not a way to make your brain bigger and smarter, unfortunately.
Do the opposite.
So it's the opposite. So you should not be decreasing any faster than 100 milligram per, I don't know if that's deciliter or what that is, DL per hour. Diego's more likely to figure that one out. To prevent that cerebral edema. Just make sure it's not going faster than 100 down. Pretty straight up for that one. And then your last one, you can end up with rhabdomyolysis leading to AKI. I always felt like that one was random. Diego, if you have a reason why that one exists there, please be my guest.
Which one?
Rhabdo.
Rhabdomyolysis. I actually
I
looked
would
this up the
assume
other.
because of dehydration. My assumption is the dehydration. Oh, it's not clear why. Okay, cool. Because I was like, I remembered looking it up, but I never figured out the correlation.
I looked this up the other day. I don't remember what it said, but I guess he said. Let me see.
Use peripheral tissue, which is muscle destruction. Yeah, I was like, my guess is it's related to dehydration, muscle destruction because of that. No, that's a fair guess. That was my correlation, but you ain't gotta know it that deep. Just know that
Yeah.
it's a possibility.
Dehydration leading to muscle ischemia, which then leads to muscle breakdown, which then leads to, that's literally what rhabdomyolysis is. Well, that makes sense.
Yay. But yeah, so that
Hyperglycemia and acidosis can contribute to metabolic stress, furthering damage to muscles.
wonderful. But yeah, so that does it for DKA, HHNS. Lord help me. As you guys can see, there's a lot of similarities, and there's only key points that really make them different from each other.
Yeah. In general, though,
And yes, this person does go to the ET.
yeah. I mean, like
That's the next.
in general, though, like the patho of why they're peeing a lot, why they're dehydrated is essentially the same. DKA also has hyperosmolar osmotic diuresis. It's just the people with type 1 diabetes, they develop ketones easily because they don't make any insulin at all. So then the ketones, the acid, becomes its own problem, which is why they start having issues so much earlier than type 2, which you see has issues starting at 600, or not starting at 600. Let me rephrase that. HHNS, we consider it 600. Obviously, it's like a gradual thing. DKA is pretty acute. So HHNS is like a gradual worsening of all your symptoms because all of that osmotic diuresis, all of that stuff that's happening that's causing them to have all their symptoms is gradually building up as the sugar goes up. With the DKA people, as their sugar goes up, they kind of have that same process, but because they make ketones, there's going to be a point where they're making so many ketones, they go into acidosis. That's kind of like the main difference.
Yeah, so if you really need to make a compare and contrast chart, that would be my recommendation to you to really make sure, because if you're getting them confused in your head, you need a way to differentiate it. So compare and contrast chart, think about that. If nobody has any questions on anything related from the above, DK, HHNS, then we can go into emergency, which isn't as long. I know Diego's got some pretty lengthy questions for you guys, so I want to try to make sure that we have enough time for that too. Okay, so now into emergency, we're just gonna start off pretty simple. Why do people go to the ED? Why would someone go to the ED in the first place? I mean, other than the DK and the above, that would probably send me there. What's your most common reason people show up? Yeah. I was like, if you look at the notes, a lot of times it's pain, a lot of chest pain. I always see chest pain, but that just might be because of the floor I'm on. Yeah, so pain of any kind, chest pain, arm pain, brain pain, I don't know, migraine, all the grains and pains. Shortness of breath or difficulty breathing is another one. Like half of the time, my reports in the beginning would go, the patient had complaints of chest pain and shortness of breath, and they came to the ED, and then blah, blah, blah. That's how all my reports started. So those were my two most common ones. Injuries as well. You know, little Tommy broke his arm falling off the bike. He should have learned to ride the bike earlier in his life, but here we are. So injuries, especially falls in older adults. Maybe Tommy was an older adult. I don't know. But, you know, with our falls in older adults, I forgot, I think it was the last day in the ICU, I was helping someone with a admission, and this older patient had fallen previous days and ended up fracturing his hip from the fall. And it wasn't very far either. So it can, like, a little fall can really hurt an older adult. So just being aware of that. Headache and fever are your other ones. Arrhythmias can technically bring someone in as well. It wouldn't surprise me if somebody showed up. I remember I had a guy in third semester who showed up because his Apple Watch told him he had AFib, and turns out Apple Watch was right. Queen. But yeah, so here's your common reasons people go. Just know, oh, I once cut a little bit of my ring finger off. Oh, but didn't go to the ED because my sister's a nurse and she told me I was fine.
But that reminds me of Kalen, your dad, when he chopped his finger off
Oh,
and then he like had you
goodness.
hold it.
Oh my girl. This is where my trauma started. Lord. I forgot how old I was. I was young. And I remember my mom driving me to my grandma's house because my dad was there, and like he cut off his finger. Sorry if this is like traumatic for you guys, but you guys are gonna see it anyway, so it's fine. Um, he cut off his finger and it was hanging on by a piece of skin, and he had it in a napkin, holding it and trying to hold the bleeding, and then I was sitting there holding the napkin with his half severed finger. Um, yeah, so it don't bother me too much.
He got
Fun
it
stuff.
back.
Yeah, is a sensation there? No, but it helps when he does baked potatoes because he can just pick them up. It's great. You know, the hot potato doesn't apply to him. But yeah, so just know your reasons why people go to the ED. Very general. Triage, you don't need to know this too much. Oh wait, no. Triage you do. The categories, excuse me. I thought I was on levels of trauma for some reason. Um, the triage categories, your emergent, urgent, non-urgent, and expectant. You do need to know these. Forgive me. Your emergent, obviously, kind of sounds just like it. It's emergent for a reason. This is the risk of loss of limb or life, and this one's an immediately treat. Life or life. Yeah, life or limb. Your urgent, kind of up there. There's no immediate threat. It's still bad. They're still in, you know, messed up. They still need treatment, but they're not going to die right now if I don't get to them. Your non-urgent, your non-urgent's your pinky finger that was cut off. Was it pinky finger? Ring finger, excuse me. Would we give them our last bed? Who, the non-urgent or sorry, wait, I oh, the urgent. Wait, I'm not sure if I understand the question. I'm so sorry. What do you mean like last bed?
Yeah, he like says that in the lecture. Like he's like urgent. You have to ask yourself, would you give them your last bed or something?
Oh, okay, I see what he means. Yeah, it's like if you only had one bed left to give, like, are you gonna give it to this person or the one who's literally dying? Like, that one makes sense. Put them in the that. Oh my God. And now on the flip side of this, it's like the one that always seems like it's gonna be keep them in the waiting room. Yeah, unfortunately, it does happen a lot in some hospitals, but is what it is. This one I always thought was kind of strange when it comes to emergency and triage. Your expectant deaths, essentially. Your super, super severe injuries, not likely to survive, and if they do, they're pretty messed up afterwards. So this person may not even be seen. They're like black tag. Um, so, you know, kind of ask yourself, like, is this person like so extensively messed up to the point that they're expected to die? Is there anything I can actually do for them? Or am I just spending a lot of resources on them? Which sounds horrible, but that's how your triage goes for emergency, unfortunately. If you're in a mass casualty or whatever, and you only have a certain amount of supplies, who are you going to give these supplies you're giving your time to? Because there's a lot of people that need your help. I had an instructor at the other school I went to that actually went, where did she go? It was sometime during COVID. She went to another country. I don't remember where, I don't remember why, but she was dealing with trauma cases like out in the field, and she was tagging people. So like black tag, red tag, etc. But crazy stuff. She got really good at that one. Okay, I brought this one up just because it was something I didn't really think about, if I'm being frankly honest. If you have a patient that comes in with trauma or some kind of abuse, maybe it's physical or maybe it's like a sexual abuse, what are some things we are going to do or not do for these patients? Oh, yeah, I would probably I would probably refer them for some help too. Forensic nurse might be involved if it's like homicide. They could be involved, yeah. Um, anything where it's like there's like a possible crime going on here, or like there's trauma or something happened, like something big bad, you're gonna pretty much like leave all your lines in place. It was something I really didn't think about. Um, when I initially was introduced to the concept. So I was like, oh, I mean, it makes sense after I thought about it, but it wasn't something that came to my mind. Because we might so easily be like, oh, okay, like, well, you don't need the Foley anymore, so let me take it out. You don't need this anymore. Organ donor. I mean, we did talk about organ transplants this past time that we all talked, definitely so. Ah. But yeah, so those are other things you could do. Forensic nurse might be involved, social worker. I think the main point I just wanted. Oh no, you're definitely right though. I mean, you're thinking like ED, and I like it. Picasso. The main thing I felt like that came up for trauma is they just wanted you to know, like, you need to leave everything in place, like leave all of your evidence. Like, for example, and this is gonna sound really bad, so you know, forgive me because this is a sensitive topic. Um, for example, if you have a patient that was sexually assaulted and you need to do a rape kit on them, you can't bring them to like wash them up or clean them up before doing the kit, because as horrible as it is, we might end up erasing essentially some of the evidence. Um, so in some contexts like that, you need to do that first to get all the stuff you need, and then we can go ahead and clean them up. That's another one that stuck with me. I was like, oh, I mean, it made sense when I heard about it again, but it was just not something that immediately came to my mind. My thought was like, I want to do something to make them comfortable. So like maybe getting them changed into like a gown or something they're more comfortable with, whatever, but that was not the case. Okay. Next is your levels of trauma. This is just really general. I'm going to kind of just run over it really quick. Level 1 trauma is your highest level of care. What are you doing over here? I see you scrolling down. What are you doing?
Sorry, I was trying to fix that and then my computer lagged.
Oh, me too. Level 2 is you can care for most injured. Your level 3, not so much. You have some stabilization and then you're transferring out, and then your level 4 is like very, very basic ACLS, and then you transfer somewhere else.
But this is just for fun. Don't worry about it.
This is just for funsies. I just put it in. I put it in before I looked over some other stuff to determine what I should put in here. So that's why I was like, let's just go over this one really quick. So if anybody's interested in working in trauma, here's all your levels. So when you hear, oh, it's a level 2 trauma center, level 1, you now know what that means. Cool beans. When you have injuries as well, I need you guys to consider the mechanism of the injury. So how did it happen? Was it blunt force? Was somebody punched? Did they get in a car accident and get hit by the steering wheel and the door and the airbag thingy? Is it a gunshot wound? Is it a stab? Is it acceleration and deceleration forces, where like you guys learned, I think this week, where you can have that like the brain move forward and back, kind of ricochet inside of the head and cause a secondary injury, kind of like that. So considering your mechanism of injury to really understand what's going on as well, just for funsies or whatever. I think you guys what was it? Am I allowed to say this for your, what's it called? For your mechanical vent test, I think there was some kind of mechanism of injury one. I think. Anyway. I would probably know this, just have an idea of it. Primary survey, so your A, B, C, D, E, what does that stand for? Absidy. It's still raining. This is horrible. I don't like the rain.
Is it airway, breathing, circulation, disability, and exposure?
That is correct, Shawty. So, exactly right. So it's basically your levels of priority. So disability, because we know our ABCs at this point. A disability is referring to stroke, so neurological disability, fracture or break, so mobility issues, and exposures such as your overdose, your hyperthermic or hypothermic, you were in a fire and have burns, and exposure to chemicals. CAB is for, that's where the exception is. If they are excessively bleeding, you are going to use CAB because sure, we could stabilize the airway, but if this person is bleeding out so fast, they're not going to have any blood left in them for that to matter. So when they're excessively bleeding, we need to stabilize the bleeding. We need to stop the bleeding the best you can, tourniquet that off, and try to make sure that they are hemodynamically stable. So that would be the exception for your ABCDE. But yeah, that's all you really have to know for that part. Your secondary survey is basically a more in-depth one. It's your head to toe. At this point, you're going to be doing more of your like little interventions. You're putting in a G tube or an NG tube or urinary catheter. You're preparing the patient to go to CT or X-ray or whatever they need to go to. So that like the primary survey is mainly stabilization. Secondary is like, okay, let's figure out more of what's going on and let's do some stuff. But yeah, emergency is pretty straight up. For you guys really need to know how to prioritize these patients. So the categories would be very important for you. Emergent, urgent, non-urgent, and expectant, knowing how to prioritize who are you going to see first is going to be something very major for you guys. As you guys saw in your lecture, you guys had a lot of questions that were like, who would you see first? And there was some that it was like, ooh, I thought I would have seen this patient first, but I misread that because the patient, what was it? I just looked at them the other day. It was like the patient was drooling, but it didn't inherently mean dysphagia. I think that was the question that I saw. In any case. But yeah, just knowing how to prioritize them would be your big one for emergency. Knowing your basic BLS. Don't ever forget your CPR is going to be 100 to 120. I think I sent you guys like the AHA approved songs that fall into that beat range or whatever, you know, whatever you want. Like somebody brought up the Sabrina Carpenter's Please, Please, Please apparently counts for that. So your song you want to jam to, I guess. Knowing your BLS, knowing how to like stabilize the airway. Diego, is there anything else that I'm missing for that? I feel like emergency was very much on priority. It was very heavy on priority.
Yeah, pretty much.
Okay.
Pretty much priority, BLS, yeah, pretty much.
Okay. So if there's no questions about any of the content, you guys can go into questions with Diego.
Wow. Okay.
Oh, he went, wow.
Wow. Okay. Here's my first question. I think I have 8.
So
Let me see
long.
actually.
You have 8. You have 8.
Okay, just making sure.
They're just long.
Yeah. Number 1, a critically ill patient with known type 1 diabetes is admitted to the ICU with DKA. The patient is receiving IV fluids and insulin therapy, and their vital signs are as follows. Blood pressure of 90/60, heart rate of 110, respirations 26, SiO2 98% on room air, temperature 99.1 Fahrenheit. ABGs reveal a pH of 7.05, PaCO2 of 25, bicarb of 8, and their potassium level is 3.4. Which of the following interventions is most appropriate? Is the most appropriate next step?
Now I have Sabrina Carpenter's song stuck in my head. Please, please, please. Please, please, please. My makeup so nice. Miss Girl was going through it, and Miss Girl was proven right, unfortunately. And maybe she was brought to tears. I don't know. Ouch. Ah, it's so cold. My hair's wet. That's the one thing I don't like is
Or her.
my hair is trying to wash my hair in the winter or like when it's really cold outside. It takes forever to dry. If I sit there with a hair dryer, I'm sitting there for 30 minutes. So I usually just let it air dry, but it takes forever.
Yeah. All right, we got a lot of responses.
Cool.
So it seems pretty much looks like most people agree. Pretty much everyone agrees. The answer is C, yeah. So in this scenario, this person, what's causing the acidosis? It's essentially the DKA, but this person is having issues with their blood pressure. They are in the need of IV fluids because remember, you got to follow your ABCs first. Even though, of course, the bicarb is on the lower end of the spectrum, you follow essentially. I mean, you could. It kind of depends on the
Context.
yeah, the context. At least
Yeah,
based on the answer choices we have here, your blood pressure would be your priority because it's your ABC, so you would choose C because it's
that's true.
fluid. When it comes to bicarb, usually DKA is treated with fluids, insulin, and a lot of the time, I don't think actually they use much bike. They don't really give bicarb too often.
No, I
It's
actually
usually
heard, sorry.
go ahead.
I actually heard like because I thought that, right? Like the C big kid, like bicarb was in it. So I was like, why don't they give bicarb for anything? And I heard one of the ICU nurses talking about it, and she was like, yeah, bicarb is just like a buffer, like a tiny little buffer. And it basically doesn't do much. It's a band-aid. Yeah, that's the word, that's the phrase I'm looking for. It's a band-aid. It's just kind of tied you over until you could get another treatment for correction. It doesn't fix your issue, yeah. It's kind of just like we need them to stabilize for a minute, but while we get other things ready to help them. But yeah, go on. Sorry.
Yeah, so makes sense. Again, just when in doubt, follow your ABCs because that's always going to be kind of the thing you should follow. So in this case, we prioritize our blood pressure because it's on the lower end. Okay, next one is a 24-year-old with type 1 diabetes admitted to the ICU with severe DKA. Patient has been receiving IV fluids and insulin therapy for the past 2 hours. Their glucose has decreased from 435 to 195, but they remain acidotic with a pH of 7.12, bicarb of 9, anion gap of 22. Potassium is 4, and their sodium is 132. The patient is alert, but they're complaining of headache and confusion. What is the most appropriate next step? Can I scroll down? Oh, can you not see the bottom? Yeah. Oh, I scroll down too much. There we go. I try to make these hard. All right, so we got a lot of D. So what's the rationale for D? Okay, so the answer, I'll just kind of start off. The answer is D. Yeah. So the idea here, what's causing this headache and confusion? And then we'll talk about kind of read back the scenarios. That's cerebral edema. Yeah. So we saw that there was a large decrease in that blood sugar over a short period of time. So we kind of mentioned how that decrease in blood sugar changes the, osmolarity of the intravascular, which then leads to fluid shifts. The fluids shift into the cells and can cause confusion because of the kind of puffing of the cerebral cells, causing the cerebral edema. So they start puffing up that part of it. In this scenario, if you guys recall, you're supposed to decrease the rate of the insulin once their blood sugar. Another thing on top of that, you're supposed to decrease the insulin when their blood sugar goes below 200, just because, again, you really want to prevent their sugar from tanking. You want to prevent hypoglycemia, but you also, again, want to prevent this really fast reduction of blood sugar. So another way to also, on top of decreasing the insulin, to help with the fluid shifts is to actually give them a little bit of sugar, even though it sounds kind of it sounds kind of um, unintuitive. The idea would be you're adding a little bit of osmolarity back to the intravascular so that the fluid shifts aren't as quick. So in order to keep those fluids from shifting too much into the head. Make sense? Questions? And then let me see what you guys actually wrote. So, yeah, pretty much Ryan. That's pretty solid. Jude, yeah, don't want to stop. Yeah, you definitely don't want to stop the insulin entirely, but you kind of want to do a little bit of both so that we kind of keep we're still managing the DKA, but we're also keeping the cerebral edema from occurring. All right, if there's no more questions, we'll move on to the next one. Number 3, a 68-year-old patient with type 2 diabetes, congestive heart failure, and a history of chronic kidney disease is admitted to the ICU with HHNS. The patient presents with a glucose of 720, an osmolarity of 350, a pH of 7.38, and a bicarb of 22. The patient has received 2 liters of isotonic saline, so normal saline, over the past 4 hours, and the glucose has decreased to 600. The patient has the following vital signs: blood pressure of 88/52, heart rate of 120, respirations of 28, SaTO2 of 96% on room air, temperature of 99.2. The patient was found to have crackles in bilateral basis upon auscultation. What is the most appropriate next step? So we're thinking about not just we're thinking about just like multiple different topics all at once, kind of combined into one. Yeah, so we have a split of answers. I'll wait for a few more people to answer, and then we'll kind of battle it out. Battle it out. Okay, looks like for the most part, the court of public, the the public shifted to B instead of C. So what's the rationale? Feel free to speak or type, and then we'll talk, or I'll talk. Okay, makes sense to me. So yeah, the answer is also going to be B on this one here. So let's think about in this situation we have crackles, right? Technically, that's considered your breathing, right? What's the difference between but this person's having issues with their blood pressure. So in this case, why did you guys choose blood pressure over the breathing? Why did you choose C instead of B? Yeah, essentially. Do you guys see the crackles as an actual problem at the moment? Okay. Are they symptomatic of the crackles right now? So, okay, yeah. What's causing their high respiration? Or what's like the likely cause?
I was
Or
gonna say, I was
multiple
like,
causes?
I was gonna say, you got a few.
Yeah,
You
you
got a
got a
few in
few.
there. Miss Girl.
Compensating. Okay. So compensation could be due to also Kussmaul's. So, well, I guess Kussmaul is more acidotic. So I guess, yeah, we're just compensation here. Um, yeah, so compensation, this patient is going probably into shock. Yeah, so kind of what I'm getting at is even though like Crackles is a B instead of a C, it's not an actual it's not causing symptoms, so it's not an actual it's just like it's a finding, but it's not causing problems right now. The patient's O2 is currently fine on room air. And like we mentioned, the blood pressure is an actual problem that we have to tackle. So it's not always just like B before C. It's actual versus potential and whatnot. So it's just kind of again going back to that like Kaplan decision tree, essentially. Okay, so here I have one that's kind of just looking at the before and after, and then determining. So here we have a patient with HHNS who has been receiving treatment for 6 hours. There's a before treatment and then 12 hours after treatment. Which of the findings is showing that the treatment is not effective? And select all that apply. So 12 hours of treatment, and this is the before and after. No, it's SATA. So it's multiple answers. I'll wait for like 1 or 2 more and then we'll talk about it. Okay, we'll just kind of call it there. So with this one, etc. Is this like a general question? What do you mean? Because there's like if you look at your Glasgow coma scale, if they're not able to talk, you kind of just put them at like the like if they're unconscious, then it kind of gets affected by that. Like you would adjust your scale based on that. Yeah. Okay, so for this one, I'll give the answer first. I think for the most part, yeah, most people got majority of it right. I would say this one's A, B, and D. So B, I guess a little subjective. The idea for why I have sorry. The reason why I have A as an answer is just because after 12 hours of treatment, the glucose has been decreased such a tiny little amount that it's very negligible. Like if we get the calculator out, it's what, 200 in 12 hours. So it's decreased by like about 17. Yeah, 12 hours actually. Like 12 hours. So, I think I changed it to 12 later. And then I didn't change it up here. Yeah, 12 hours. So like it's changing like shit, right? So that I would consider that to be like this is a sign that this isn't improving. But I can see subjectively like the other perspective where you're like technically it's going down. But that's just how I interpret it is that the value is not going down at a rate that I like it at. The serum osmolarity, again, it's going down, but it's going down. It's like barely going down. I think the key thing to keep in mind here, it would be the Glasgow coma scale. So a normal Glasgow coma scale should be 15. That's like the max. So even though this number is quote unquote stable, it's been consistently 12. That's not what we want to see. We don't want them to we don't want them to be at 12. We want them to be a little bit higher. Um, we want them to be actually improving. So it's just something to keep in mind. Like the goal of your treatment is to improve their glucose level a significant amount, improve their osmolarity, and try to improve their their GCS as well. For the potassium, in this scenario, it doesn't. It's technically it's like about the same. You're like the purpose of the treatment isn't directly the potassium, but I can see how some people put that. And then ketones wouldn't be there anyways. It's fine because HHNS. Yes, exactly. So patient would be improved. If the patient was actually, if the treatment was effective after 12 hours, we would hope that they would be more alert. So in this case, the Glasgow coma scale. Make sense?
Yeah.
Okay. Here, I think the last three are ER, like emergency triage questions. A nurse in the ED is assessing 4 patients. Which of the following should be prioritized for immediate care? A 55-year-old with a history of hypertension who has a blood pressure of 200/110 and a heart rate of 90 who complains of headache. A 40-year-old with severe epigastric pain, nausea, vomiting, BP of 95/55, heart rate of 110, complaints of abdominal tenderness. 30-year-old who was involved in an MVA presenting with blood pressure of 85/50, heart rate of 120, SiO2 of 90, complaining of chest pain and shortness of breath. Or someone with COPD. Oh yeah. Yeah. Good night. Good night, Natalie.
Say
And
wife
yeah,
duties.
wife duties. And then D is a 70-year-old with COPD, presenting with shortness of breath, SiO2 of 88 on 2 liters, BP of 112, 71, 97, 26, 106, who complains of malaise. Yeah, this one's gonna be C, yeah. So here we see the chest pain. The chest pain's gonna be important here. This person's been in an MBA, they have short chest pain, shortness of breath. This one can be consistent with hypertension. It could just be the hypertension itself. Now, things might be a little bit different. If they complained of a severe headache, this person could be having a stroke. But this person's also having issues with this guy's crashing out, having shortness of breath, very symptomatic. Chest pain, shortness of breath. There's a chance that they have chest trauma and have ventilation issues. So that would be your airway. This person could have some different a lot of different things happening, but it doesn't take priority of C. And then D, even though the SATO2 is 88, this person has COPD, so that's kind of expected. Based on their vital signs, this person is probably has like a fever. Well, has a fever. Probably it has an infection. So it's something to keep in mind, but not going to take priority over the person with the chest pain, shortness of breath, crashing out. Okay, number 6, an emergency room nurse is triaging victims of a multi-casualty event. Who should receive care first? Person with pale, cool, clammy skin, the mother holding her crying child, a conscious male with a head laceration, or someone with a simple fracture of the lower leg. Yeah, so we all picked A. So this person's probably pale, cool, clammy skin. Sounds like uh circulation issue, probably going into shock. Here, there's not really too much going on from what we can tell in the answers, so we're not going to choose that one. Here, conscious male, with the fact that he's conscious, I mean, I'm sure we're going to assess him, but the fact that he's conscious means that they can wait. And someone with a simple fracture is not really going to be priority. Okay. 7, a nurse is triaging in the ED. What should the nurse prioritize? Who should the nurse prioritize? 22-year-old with a painful and swollen right wrist, 45-year-old with chest pain and diaphoresis, 60-year-old reporting difficulty swallowing and nausea, 81-year-old with respiratory rate 28, temperature of 101.
Yeah, well, that's good. I think I'm gonna find the ticket right here.
Okay, I'm seeing a split of opinions here. So I'll kind of start by giving the answer. So the answer is going to be B. The reason, and I see the rationale between C. So the difficulty swallowing and nausea, this person's at risk for aspirations, which could be an airway issue. And that's important as well. But kind of again, not just think about A versus B versus C, but also consider actual versus potential. It's definitely good that we're thinking about the potential. But again, if this person's having actual chest pain. So here, C only has a risk, which means it's potential. So with these priority questions, think about ABCs, but also think about actual versus potential. Think about acute versus chronic. So things to keep in mind. Make sense? All right. And then last one here is a trauma patient with multiple open wounds is brought to the ED in cardiac arrest. Which action should the nurse take prior to providing ACLS?
Oh, sweet. Sweet, so I saw sweet. Come on. Ah, yeah? You. Oh.
Now, I will say I got this question from Quizlet. I will say that. This one was very funny. This one was very funny because this one's actually D. It's following the logic of if you're in an airplane, you give yourself the oxygen first. Because of they have multiple open wounds, the idea is before you perform because in this scenario you're thinking that you are about to do CPR and connect the pads. It actually wants you to put protective equipment first because you would rather protect yourself first than do the CPR. I just thought it was a funny one. Although I definitely understand the reasoning why a lot of people I think it'd just be like what, gloves?
All you can get on, that's all you can get on.
Although I definitely understand the rationale for B. Although I guess if they're already in DED and they have cardiac arrest, it's kind of people are kind of already there. It's kind of a weird one. I think the rationale on that one doesn't really put too much on why it's not B, but I mean, it's not. I don't pretty sure this question is not on the exam, but
No.
that's kind of the rationale. It's the rationale is you take care of yourself first before you take care of others. Because if you don't take care of yourself, then if something happens to you, then that person's gonna go down anyway. I
Oh
understand,
no.
but it's again, it's kind of like that idea. If you get harmed that way, then you can't continue on, and then you're. I don't know. It's kind of a funny question, but it's kind of the same concept as you put you put the air mask on yourself before you put it on your child.
Planes. Pick your favorite kid.
Yeah. Pick your favorite kid's funny.
No, I saw this video with Spirit airline person giving that announcement, and she was like, "Yeah, pick your favorite kid and put the mask on them first, after you do
Uh,
your own."
After you do your own, because first you have to put yours first, because you're the person that's um
Exactly.
you're gonna do the saving. So if you're down, then they're down because they can't do it themselves.
Mm-hmm.
I mean, in this case, obviously, like, yeah, it's kind of just like just protect yourself. Keep in mind of protecting yourself.
It's like if someone's pooping their brains out and they have C. diff, I'm not going in there without gloves or anything. I'm sorry. I'll
Yeah.
clean them up. I promise I will. But I'm not getting C. diff. No, thank you.
And I get it here because like this is like okay, this person's dying, like potentially dying, but it takes you like 2 seconds to put on the gloves. That's the kind of idea. And it's like long term, if you get sick from whatever they have, you're not there to save other people. I think that's like the rationale. Anyway, that one's kind of a weird one, but it just kind of was like, I need to find an eighth question.
Feel like I have to make it even.
Yeah. Okay. Anything to add on, Kaylin, before?
No, not from here anyway. I feel like a lot of the questions that you had were very in depth, and I feel like DKA and HHNS and emergency are pretty straight up. It's just the prioritization of emergency gets kind of wonked out. But
Yeah,
I know he gave you guys some examples that are good.
I feel like for the most part, it a lot. I think this test was generally like not like was considerably simple. Like was definitely more simple than any of the other ones. I think
That mean
relatively.
don't mean don't study. We're Nydia. I saw her in here.
Yeah, don't that doesn't mean don't study, but just keep in mind. I think you guys have finished all the like the really hard exams, and I'll be surprised if the average isn't like very solid on this one.
Yeah.
There you guys go.
How do I stop the recording?
Well, you don't, because I'm the one
Oh.
recording.
Oh,